Hello, everyone. Thank you for your invitation to this event. Sorry I could not attend in person. My name is David. I'm the Sustainable Medical Practice Advisor for Doctors Without Borders. And I wanted to share with you today some of our project and communication tool that we use to explore the role of infection prevention and control in delivering sustainable healthcare system. I will start the presentation with a little bit of background to cover what MSF is and its environmental commitments. And then I will share with you how we are engaging our medical teams, how we can be safe and sustainable, and explore how we collaborated with our IPC teams more specifically. Just to set the stage for everybody, so MSF is a really big international uh, non-governmental organization, NGO. It's been around for 50 years and has 5 main offices in Europe. And we also have an international office, a body that supports these 5 offices. And I'm part of it. There's a climate and environment team, and I'm part of it. MSF is working providing medical care in 75 countries. We have around 50,000 staff, up to 70,000 during some emergencies. And when we look at hospital activities, we count around 8,000 to 10,000 hospital beds. But you can see that we have very diverse activities cover tuberculosis, malaria, hospitals, but also outpatient activities, mental health, and so on. Something that is quite interesting is to see that actually our operational presence is very linked to places that are very vulnerable to climate change. So it brought the need internally to take some commitment to it. So after some work and discussion, we integrated in our strategic plan to reduce our carbon footprint in 2021. To do that, we calculate a footprint and build a roadmap towards 2030. What does it look like? It's a bit different than a regular hospital. Our footprint is 50% goods and services, but a lot of it is transport. But otherwise, it's very linked to our medical activities. We have an environmental roadmap to bring the result that we want, the 50% reduction, and medical practices are part of it. Now that this is said, how can we decrease the environmental impact from a medical perspective? And how can we identify the role of medicals? This shows that IPC professionals are central in our efforts to render healthcare system sustainable and are a key pillar. And all of it stems from a reflection. When we communicate it, we know exactly what are the emission, the role from procurement, transport, and energy, but what is the role of medical? And that's what I want to explore with you today. Of course, to reach our objective, we have 6 main domains of action. We can see that these domains are mostly linked to our supply chain, from the supplier to the transport, facilities, and end-of-life management. However, this would not be very different from any company, a hotel, or a restaurant. But in a healthcare context, it's quite a bit different. So we're gonna explore a bit what are this set of parameters, the factors that influence our consumption of single-use medical items, and see then what can be done. To do that, I'm using the work of an economist, Mr. Kaya. Mr. Kaya, in 1993, built an equation that linked the resource used by a population to grow its economy and the pollution that was generated because of it. We can use his approach to make the link between the resource we need for our medical item, the item we use to provide care to a patient, the amount of care we provide, and the number of patients we care for. To start this demonstration, I begin with all the resources that MSF needs to manufacture, transport, store, and deal with the end of life of all of its equipment. So here you have aluminum, steel, plastic, wood, but also fuel, electricity, and all the waste that are linked to producing these resources. I'm calling that the use of resources, and then I start the mathematical work as I previously described. And I start by saying the use of resources is equal to itself. It's a bit abstract, but at least this is always true. Then we will multiply and divide by the same factor. Stay with me here. It's very simple. I multiply and divide by the medical item that we need to provide care. I multiply and divide by the care we provide to a patient, and I multiply and divide by the patient we care for. Doing so, we identify 4 key factors that influence directly our resource consumption for providing care. We see that we need resource per item, item per care, care per patient, and number of patients. Then we can explore what we can do. On the first one, we explore the impact per item. Here, we include the manufacturing, transport, storage, and disposal of the equipment we need. An example to illustrate this, in MSF, we analyzed our purchasing of goods, specifically medical goods, and we realized that 2/3 of it were single use. We wanted to do some analysis, which we did. What we found is that by quantity, PPE is a big player with gloves and masks. Then devices for injections were the second big player. We did the same analysis by weight, and again identified gloves and PPE in general as a big player, and again devices for injection. But we wanted to know more because, as you know, all of our medical items are made of very different material: plastic, latex, steel, aluminum, paper, and all of it have very different impact on the environment. What we have found is that personal protective equipment, including non-sterile gloves, isogen gown, and masks, were the family of items that had the most environmental impact. The second one being devices for injection. Knowing this, I come back to the equation. We can look at what we can do to reduce the impact per medical item. One option is to implement reusables. That's a very good principle in general. It works for personal protective equipment in the operating theater, for example. So we have in our catalog reusable surgical caps, reusable surgical gowns, also drapes, and we are pushing for implementation. However, we need industrial laundry and sterilization, and this is not available in all of our projects. Something else that we can implement for the item themselves, we are pushing for a switch to phase out latex and go to nitrile, simply because they are a lighter alternative. And looking at our context with the transport of all the items, the long distances, and the way we deal with waste, doing this would reduce the freight by 100 tons per year, and the medical waste produced by 100 tons per year as well. So this is ongoing. So this was just to illustrate this third parameter of impact per item. Then we can work on the number of items per care. So for that, we need to be efficient, responsible in our use of resources. We can also choose medical techniques that use a bit less equipment. An example for this that I'm sure will speak to you all is to push for an early switch from intravenous treatment to per oral. It is already in our recommendation, but that needs implementation. I was mentioning medical techniques, switching from one mode to another of anesthesia, so pushing for regional anesthesia rather than general, use much less equipment. It's better for pain management, shorter length of stays, better for patient satisfaction, and it's less carbon at the same time. And the last example that I'm sure will speak even more to you all, the rational use of glove. This was piloted by the Gosh Hospital in London a few years ago, and we contacted them and tried to implement that in our context. So this was in Lebanon, and we were very happy to see that we reached a similar result with a 40% reduction of glove consumption per consultation, with massive co-benefits for quality of care, reduction of healthcare-associated infection, but also less transport, less stock, and less waste. And the key message here was to perform a risk assessment in all situations, We're also pushing for general rational use of personal protective equipment that is under development. We also brought that message during the World Hand Hygiene Day last year, where more than 10 projects from all MSF offices submitted campaign proposal to raise awareness on this issue. Third parameter, the care per patient. How effective are we to bring care to the patient so the treatment will be effective? And so we could bring the least number of treatment with the least number of days, the least risk of side effects, the least risk for patient safety incidents, and improve adherence to treatments. This could also be called a secondary, tertiary, and quaternary prevention. For that, WHO is very clear. To be effective, we need quality healthcare. And quality healthcare is safe, timely, evidence-based, equitable, and patient-centered. So providing the right drug, the right dose at the right time in the right patient, making sure we have early diagnosis and treatment, that our practices are evidence-based, that the patient receives the care they need, and that the treatment is appropriate, adapted, and acceptable by the patient. As IPC professional, we can illustrate that very clearly. How can we provide safe care in MSF? We measure patient safety with a list of indicators. One of them is the score of IPC implementation. This is measured through a list of indicators, and here are some of them. We need IPC supervisor, committee, an action plan that is implemented. So structure and processes, but also outcome, respect for bed spacing, the different pillars that are implemented. So this is part of our patient safety policy, and this, as you can see, has a direct impact on our consumption of resources. And the last parameter is disease incidence. So how can we minimize the need for healthcare services? For that, we need prevention, so primary prevention, health promotion, and disease management or patient education. A good example for that is the Make Every Contact Count campaign that makes sure that every opportunity of contact with the healthcare services is used for health promotion, education, and bring messages. And in this case, in MSF, we use this tool, the vaccinometer, that allowed us to easily check on under 5 vaccination and catch up on essential immunization program as recommended by WHO. So my message here was to tell you that there are different levers that we can use to reduce our impact or decarbonize healthcare, and that IPC has a key role to play here. One of the key advantages is that this view has a multiplicative effect. So efforts of decarbonize can be shared. Overall, we see then that we have 4 key parameters that we can work on: resource per item, item per care, care per patient, and the need of healthcare services. And we've identified the main levers to mitigate this impact. So we need a sustainable supply chain with the most sustainable products, low carbon procurement, low carbon transport, low carbon storage, and proper waste management. We need to be efficient and responsible, so resource stewardship in the way we use items, rational use, but also good medical techniques, good stock management and forecasting, and good maintenance of our equipment. We need to be effective in the care we provide, and WHO tells us that quality of care is key here through safe, timely, evidence-based, equitable, and patient-centered care. And we can reduce the need of healthcare services through prevention. You have a key role there, but disease management as well, so patient education and health promotion. Overall, a sustainable healthcare system is a combination of these 4 key factors, including strong IPC services. All have their importance. And to bring this message, we need specialized health professionals that are used to raise awareness, promoting behavior change, training healthcare workers, but also forecasting, stock management, waste disposal, rational use. And in MSF, and I think in your facilities as well, the most experienced professional, health professional for this is you guys. You guys and our IPC teams deal with these topics on a daily basis in all wards, and so in a transdisciplinary manner, involving it and services. So for me, IPC have been central in our efforts, and they still are, and they are really key in implementing sustainable medical practices. Overall, we can say that proper IPC practices is sustainability, and that therefore there will be no sustainable healthcare without proper IPC practices. A very last reflection, considering our role as medical, when we ask the public, who do they generally trust to tell the truth? The politicians score the lowest, and the nurses score the highest. So what we say and what we do matters. I'll leave you with this consideration, and I'm happy to answer any question by email if you even wanted to reach out. I said sadly I could not be present,